My name is Lisa. I'm one of the secretaries. I'm going to be talking about procedural sedation today. So let's just go over some objectives. We're going to do a little bit of definitions, some indications and contraindications about the PrEP, entitled CO2 monitoring, and some medication selection. So procedural sedation, an analgesia refers to a technique of administering sedatives and associative agents with or without analgesia to induce an altered state of consciousness, allowing the patient to perform or unpleasant procedures. So sedation comes in different levels, from minimal to general anesthesia. And sedation is on a continuum. It's not really discrete phases, and medications, specifically sedatives, can cause rapid changes in sedation. Analgesia specifically refers to pain control without sedation, but these medications can also cause altered mental status. So we have first minimal sedation, which is basically mild anxiolysis and pain control. Then we go down to moderate sedation, which is defined as a patient who responds to light touch or light stimulation. And these patients are maintaining their airway. We then have moderate sedation, which is defined as a patient. We then have deep sedation, which is a patient who requires painful stimuli in order to look for a response from them. Sometimes these patients with monitoring and assistance. And then we have general anesthesia, which is defined as a patient who has no purposeful response to repeated painful stimuli, and these patients always need airway protection. Somewhere in the middle, we also have dissociative sedation, which is a trance-like state in which patients experience profound anesthesia and amnesia, retain their protective airway reflexes. And this is only achieved with ketamine specifically. And usually these patients fall somewhere between moderate and deep sedation. So some indications, there's no specific indication that's like a hard rule as to when to do procedural sedation. We would just do it in procedures that can cause significant pain or anxiety or would otherwise be impossible without it. So some examples include close reductions or dislocations, cardioversion, complicated laceration repairs, LPs, INDs, specifically in the periapial region, or chest replacement. So there are no absolute contraindications to procedural sedation as well, but there are certain populations that weigh risks and benefits a little bit more. So we have the elderly, and they generally have higher rates of adverse events. They have increased sensitivity to medications. They're generally on more medications, so polypharmacy interactions can be something as well. They also have higher peak serum concentrations of a lot of the sedatives that we use. So if we do decide that procedural sedation is the best thing for them, we need to start with a lower dosing, go slower, and just reassess them. Other things to keep in mind are patients with significant comorbidity, specifically like ASA classification 3 or greater, generally have increased susceptibility to cardiorespiratory depression from these medications, so they also need to be monitored. And then it's always important to assess aspiration risk in these patients, so it's important to know last oral intake. But this should not dictate when we do the procedure. It should be the urgency of the procedure that dictates when, especially since clinically significant aspiration is unprecedented. It's just something important that we do need to keep in mind. So for our preparation, we need to do a full assessment of the patient. We need to get a complete history and physical exam, identify any medical illnesses or medications that they're on that could affect procedural sedation, identify any medication allergies, and then really important to do a really good airway assessment and to make sure that you have backup in case something goes wrong. We always need somebody who's doing whatever the procedure is, an additional person to do the procedural sedation, because this is a full-time job. The patient needs to be monitored so that nothing goes wrong. And we always need to have backup equipment, airway cards, O2 suction, resuscitative medications, defibrillator, and some pharmacological reversal agents for the medications for procedural sedation. So in terms of the monitoring, we use capnography, which is a non-invasive measurement of the partial pressure of dioxide in an exhale breath as expressed by the concentration of carbon dioxide over time. Specifically, we're looking at the end-tidal CO2, which is the maximum CO2 concentration at the end of each breath. And up on the monitor, we'll have a number for the end-tidal CO2 as well as a wave. To assess a patient's oxygenation, we're using pulse oximetry, but for ventilation, end-tidal CO2 is the best way to assess this. So oftentimes patients who are getting procedural sedation are on supplemental oxygen, and therefore pulse ox is not an accurate depiction of the patient's respiratory status. But when using end-tidal CO2, you get a much better picture of what's going on. So this is a normal curve. So here is when exhalation begins, and then we travel from point A to B. This is called the dead space ventilation, and it's the beginning of exhalation where the dead space is cleared from the upper airway. Then we ascend from B to C, which is the ascending expiratory phase, where we have a rapid rise in the carbon dioxide in the breath stream as the carbon dioxide goes from alveoli to the air. And then we go all the way from C to D, which is the alveolar plateau, and the carbon dioxide is reaching a uniform level in the breath stream from the alveoli all the way to the nose. Point D over here refers to our end-tidal CO2, and that's the maximum carbon dioxide concentration at the end of the breath. And this is the number that gets displayed on the monitor. And then we go from D down to E, which is the descending inspiratory phase where the inspiratory cycle begins and the carbon dioxide concentration drops off. So a normal waveform means that the patient's airway is patent and they're breathing spontaneously. Normal end-tidal CO2 values are from 35 to 45, and this shows that the patient is adequately ventilated and has. So there are some alterations in the waveform that can take place, and it's really important to recognize these to know what the patient's respiratory status is. Okay, so patients who have an adequate tidal volume but a low respiratory rate, this causes the carbon dioxide to rise, and we have an increase in the end-tidal CO2 over here. This is a patient who is hypoventilating, and it just takes generally longer for them to exhale, which is why we higher and higher. Patients who have an increased respiratory rate but decreased tidal volumes have less CO2 getting to the sensor and therefore have a decreased CO2. These patients are hyperventilating, which causes the curve to be lower and therefore. If we see a sudden loss of waveform, we know that this is because there's no carbon dioxide getting to the sensor. So either there's a malfunction in the equipment, or this could be that the patient is not breathing. So we need to make sure to check on the patient, stimulate them, give artificial breaths if necessary, and intubation. Patients with obstructive lung disease have an impaired expiratory flow and therefore have a grounded ascending phase and have an upward slope in the plateau. And this can be also seen in patients with bronchospasms. So if you see these sharks, about bronchospasms. So for medication selection, it's really important to match the duration of the procedure with the medications that you choose, because this will help you make sure that the patient is not sedated for too long. So in medication choices, we want a rapid onset of action, a short duration of action, and medications that maintain dynamic stability. So we have Propofol, which is lipophilic and therefore crosses the blood-brain barrier very rapidly. So it has an onset of action about 40 seconds and lasts for about 6 minutes. It has sedative and amnestic properties, but does not provide any analgesia, so we need to supplement that with medication. Some important side effects to keep in mind: hypotension due to myocardial depression and respiratory depression as well. And respiratory depression can be worsened when using other analgesics that can cause respiratory depression. Ketamine is a dissociative agent, as we had mentioned earlier, and it has sedative, amnestic, and analgesic properties. This also preserves spontaneous breathing and airway reflexes. Its onset of action is about 30 seconds and lasts between 10 and 20 minutes. Some side effects can include tachycardia, hypertension, laryngospasm, nausea, vomiting, and emergence reactions. So laryngospasms are specifically higher incidence in patients with anatomic airway abnormalities such as tracheostenosis or tracheomalacia, or in patients who are undergoing procedures that involve significant stimulation of the airway. So just keep that in mind when choosing your medications. Emergence reactions are actually the most common side effect with ketamine, and they can vary in intensity. For very severe ones, also treat Vaseline. Instead of using either ketamine or propofol independently, they act synergistically when used together and can be used at lower doses, decreasing the side effect profile for either of the two medications. So we would have less respiratory depression, hypotension, and than propofol alone, and less nausea, vomiting, and emergence reactions. Etomidate is a really good sedative medication, but it doesn't have any analgesic effects. Its onset of action is almost immediate, and it lasts for between 5 and 15 minutes. It's a good choice to maintain cardiovascular stability. Some side effects include myotonus, respiratory depression, nausea and vomiting, and if given in a continuation infusion, which would not in this case, it could cause some adrenal suppression. So benzodiazepines can be used as well, specifically midazolam. It's lipophilic and crosses the blood-brain barrier well, but also accumulates in adipose tissues. So this is something that can have an effect in morbidly obese patients because it can last and linger a little longer. It gives some anxiolysis and analgesia, but there is no amnestic effect. And its onset of action is 2 to 5 minutes and lasts for about 30 to 60 minutes. So usually we tend to avoid this just because we have other medications that work a little bit quicker and have a little bit of a shorter duration of action. So it's just safer to choose something else most of the time. And then we also have short-acting opioids. Fentanyl can be used in combination with Propofol or etomidate to give an analgesic effect. It's significantly stronger than morphine. Its onset of action is 2 to 3 minutes, and it lasts for 30 to 60 minutes. It can cause respiratory depression together with some other medications, so that's something to keep in mind, and always important to have a reversal agent naloxone. So in order to be able to get the patient ready for discharge, we need to make sure that their vital signs are stable, that they are AO times 3, that they're able to get up and ambulate, that they're tolerating PO, and we want to make sure that they have somebody to take home safely, just in case some of these medications are still lingering in their system. So in summary, it's important to use end-tidal CO2 monitoring, especially in patients getting supplemental oxygen. Be prepared to place a definitive airway. Medication selection is based on the duration of the procedure and the level of sedation that is required. Questions?
Questions, comments?
Just a comment about that capnography, right? So, right, let's say you're using opiates, right? It causes respiratory depression. And just like you were saying, if your respiratory rate goes down, your capnography be higher, right? Because each breath that you're giving will have more CO2 in it, but you're not ventilating well because your rate is down. Using some of the other sedatives might cause hypoventilation and actually have capnography decrease, right? Because if you're just not taking deep enough breaths, your rate might still be preserved, but your tidal volumes might be preserved. And as a result, you're still hypoventilating, your ventilation is still down. But with each breath, if it's really shallow, you might not be delivering back enough CO2. So you have to remember, based on which agent you're giving, you have to know kind of what direction will fit your capnography. But when in doubt, if you know what it is at baseline and it's going up or down, that's probably an issue.
Yeah, I agree. I always say that. Can I get an idea of where your baseline is and just look for significant changes? That your first was always patient. If you don't have capnography, as Lisa kind of implied, I wouldn't put the patient on supplementary oxygen because it's going to falsely increase your O2 sat. Patient behind the 8. So if you don't have end-tidal, just leave them off any supplemental oxygen, and your pulse ox will be a better gauge.
My question kind of for the attendings, like Propofol kind of some like withdrawal and why or why not?
I like it a lot.
Yeah, I think it's great.
It's only if the patient's blood pressure is a little soft, then I but I like you. I think get a really nice reduction with it. I think really get good anesthetic with it. But by using the ketamine, really do reduce a lot of the concerns with
Yes, ketamine MSK reduction to get too much like sickness for the severe overdose, so it helps to get that to get full. Another side thing is just documentation. It's something that always comes up just from an admin perspective. Is like you don't document this well enough. You should, and also that you should give all these patients discharge instructions for having on it. Sedative medication. Don't come up here.
I really like you highlighted like thinking through the procedure that you're doing and having that really guide your anesthetic choice as opposed to familiarity. Right? Definitely the etomidate one is the one I was sense, but it's not great for every patient. If I'm just doing a chest tube, if I'm just doing something very quick, I just need that 5 minutes of bridge, perfect. CAT scan patient. I'm going to use that for tumor fracture reduction. No way. It could take way too long. In case Ketamine. I wonder if it fell out of vote not because there were complications, but just simply access. I mean, sometimes get that second medication, it's trickier, and so with enough coverage, it's much simpler to get a person.
But technically, right, every like institution technically has propofol or not for our patient. Right?
Yeah, we are allowed to. Some institutions, I would say, your sedation is governed by the anesthesia department. And I was incredibly offended when I learned that somebody like, fellow residents who graduated went to other places were allowed to because they were taught that only someone with definitive airway ability, such as anesthesiologists, they're probably the wrong way. But yeah, here we are allowed to use it. Yeah, you will see us making different decisions based on you two dose of Versed, about 10 minutes of paperwork, and whatever.
The other thing I would say too is be careful with ketamine. There are different concentrations.
Yes.
I've run into that at downstate a lot recently. They have a super rated kind. So you really have to make sure what kind you have. And ideally you should be drawing up yourself, not more draw.
Yeah, and I don't mind the nurse drawing it up, but I always look at the vial again. And before I even start, I really, in my mind, understand how much is 1 ml of this. So that way, when you're trying to titrate it, you get more, especially Propofol, where you tend to have extra of both, and where you're just giving, kind of depending on how the patient looks and what things you're giving, so you just have to have really clear in mind that I agree. You don't have to draw it up, but if it's drawn up to me, I then look at the actual vial, and in my mind, I calculate it, and then I also make a note to myself if I need to give or how much is each.
That's great, thank you. If you do have to use reversal agents, your observation period afterwards should